Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. If this resonates with you, please follow me on Apple, Spotify, or your favorite podcast app. Hello, and welcome to the Sleep is My Waking Passion podcast. I'm your host, Dr. Alison Kole, and today is going to be a very special edition of this podcast. We are going to be speaking with Dr. Esther Park, who is one of the founders of the Oak Health Center, as well as our practice manager, Mr. Andrew Brewer. I'm so excited to have them on the show today because this is a very special edition. We are going to be talking about the importance of sleep and mental health and that relationship, which can get quite complex. This is going to be the Oak Health Center edition, where we get into the nitty-gritty of how our relationship came to be. And we're going to have a lot of fun getting a little bit deep into what it means. What is the relationship between sleep and mental health? What does the data show us? Now, in putting this together, Andrew actually had come up with several really amazing questions. He is not a clinician, and his questions were so on the mark. I really wanted to think deeply about how we incorporate them, because he's also going to be the person who's looking at us going, you know, guys, nobody's going to know what you're talking about. There's doctor speak going on here. So without further ado, welcome, Andrew. Welcome, Dr. Esther.
Thank you.
Dr. Esther, can you tell us a bit about how you and Dr. Mejan came to decide on kind of venturing out into your own and starting Oak Health Center?
So in general, regarding venturing out to become a comprehensive mental health center, we truly wanted to provide the community where not only they can get psychotherapy, psychological testing, but also quality psychiatric medical care. And then along with that, all these other ideas of including other specialties started to come up. And that's when we met you, and we were very excited to include a sleep medicine program that you are heading up for us.
Hooray! I am so grateful that you guys took the chance on me, really. Being someone who was a sort of a friend of a friend of a friend, a third-party referral, if you will, having that initial conversation, I really wasn't sure where it was going to go. But I love the subject of sleep medicine so much and really wanted to be able to create a program that I didn't feel was being run or mandated in a way that was more traditional medical model. That's what the experience that I came from. And I wanted to try to branch out and make sure that I created a program where patients not only have access, but they have access to a physician who wants to spend the time with them to really understand what their issues are and kind of look at the whole patient, if you will, not just one aspect of them or treat one condition and ignore the rest of what's going on in their lives. So this has been a really exciting partnership. I know we're going to continue to grow together. So Andrew, without further ado, do you want to say anything or tell anybody a little bit about your practice experience? I'm not trying to exclude you.
Thank you.
You're
Thank
in
you.
this.
I appreciate the opportunity. I am excited to have this conversation with my experience working with such talented and brilliant doctors, such as you, Dr. Kole and Dr. Park. I was excited to come on board and moderate and share some questions. I thought that somebody in my position, where I don't have that medical background, the clinical background that the two of you have, I want to hear what it sounds like for someone like me, because I think your patients and your clients, they're the ones that really are going to benefit from understanding how sleep and mental health go together. So when we were able to create this partnership, it was so exciting because I just think people don't understand how important sleep can be for mental health. And that actually brings me to my first question that I'd like to toss to the both of you is, why does sleep matter so much in good mental health? Why do they drive good mental health?
Andrew, that is such a wonderful question. So I'm glad that we're starting off with that one. When I think of that question, we can think of our own personal experience, right? Hey, how do I feel when I get several days of crappy sleep? And I've been there, and I've shared with you guys my struggles with sleep.
Mhm.
I, like many people during the pandemic, really, that sleep issue escalated for sure and became more of a struggle. But aside from my personal experience or the experience that I've heard many times from my patients, the reality is there is data to support this relationship. And that's what I want to briefly kind of go over. What do we know in general about what the state of affairs is with sleep health in this country? Well, the reality is that up to 30%, like literally a third of the American population, suffers from difficulty with sleeping, also known as insomnia. A quarter of the folks in America actually experience what we call excessive daytime sleepiness. They actually feel so tired that they struggle to keep their eyes open. If we step aside and we look at what the state of affairs is with mental health, almost 20% of our population is suffering from some sort of a mental health disorder. And it's been well documented in the media that COVID, the pandemic, actually accelerated this issue, put us into a mental health crisis. So we do know that there are people that are suffering out there. There was a study in 2011. So this is not new information. It was a meta-analysis, and it looked at 21 longitudinal studies, meaning that you take a group of people, a large group of people, and you typically follow them for many, many years. This is an observational study. It's not a randomized control trial. But what they found was that there was a twofold increase in the risk of having depression if you had insomnia. That's mind-blowing. That's like twice the risk if you're not sleeping well. The other data that I wanted to point out was that there was another very large study, a meta-analysis of 65 different studies. And really what they were looking at is, okay, so if we're saying, for the sake of argument, that there's the personal experience with having difficulty sleeping and how that negatively impacts our mood. And then there's data to support that there's an association between not sleeping well and having a bad mood. Okay, well, what if we actually help people sleep better? What does that do to their mental health? And the bottom line is that various interventions were looked at, because if you can imagine, there are so many different ways to try to manage folks that aren't sleeping well, cognitive behavioral therapy, etc. And what they found was that an improvement in sleep quality actually did translate to an improvement in mental health quality. So the data is there. I think it's undeniable, really. I don't think I need a randomized trial to tell you that clearly there's a relationship between the two. Esther, any thoughts?
Oh, yeah. Without restoration of sleep, no matter what type of treatments I have given, sometimes there will be a very slow progress in improvement and restoration and recovery of those suffering from depression, anxiety. Sometimes I actually approach cases and try to improve their sleep first, because sometimes that even alleviates so much and helps detect, was it just a pure insomnia issue, or the insomnia was one of the criteria symptoms of what they're going through.
Wow. So not only we're hearing the data, we're hearing it straight from the clinician mouth. This is seen in the psychiatric world over and over and over again, this relationship. I can say from the medical perspective, I would agree wholeheartedly, but it's a really unique perspective to hear it from a psychiatrist, because I will tell you, that is not often my experience, that the psychiatry aspect of things is often left out when you're in a standard medical model, depending on who's you're referring based. So very interesting stuff. Thank you for that.
May I actually add to that question? Why do you think that you don't see the partnership between sleep and mental health, despite the fact that it clearly is, it should be integrated? What stops kind of the medical world from having more stronger relationship between the two types of treatments in terms of mental health treatment and sleep coaching and sleep health?
Oh, that's such a great question. I don't know any data to support this. So this is just going to be my personal observation and opinion. But, the focus of the traditional medical model that I was in, and I happen to be a lung specialist as well, so I'm a pulmonologist, critical care doctor, is I would often be referred patients who had medical comorbidities because there is very strong data that supports issues related to your heart, such as atrial fibrillation and other medical conditions, high blood pressure, diabetes. So I would often get these referrals from a medical doctor who's treating these conditions and is concerned that there's something else going on. What's interesting is psychiatrists often, at least at my institution, they had a completely separate electronic medical record. There's special protections for psychiatric information. And so a lot of the elements of that evaluation, even if the patient happened to have depression or anxiety and they were seeing a mental health professional, not just their primary, I often wasn't privy to that information. And there's also the perspective of the patient coming in and seeing you and is like, well, I'm here for my medical issue and my doctor thinks it's important, but they yet don't make that association themselves. So they tend to de-emphasize the part where they actually have a fairly significant psychiatric history. And other than a personal conversation where I reach out because I'm specifically concerned or want to discuss, medications or treatment options with the psychiatrist, it's really like playing telephone tag a bit. Can I get in touch with them? When are they going to call me back? Do I have to make a second phone call? So it's just not easy. That communication seems to be blocked. At least that was my experience with the practice I was in. Esther, what's your experience been like?
My experience, I would have to say I did a family medicine residency for 1 year and then I switched to psychiatry. So I was able to see that medical model and that world before going into psychiatry. And I remember patients themselves don't voluntarily share that they have depression and anxiety. So sometimes they come to the medical clinic, like the family medicine clinic, and say, please fix my sleep. So unless the clinical provider directly asks all of the differential diagnosis questions, which means all of the possible reasons for sleep problems, such as depression, anxiety, the patient themselves would just say, just give me a sleep med.
Right.
So I think that association, just like what you said, they don't associate that I'm having sleep trouble because I'm depressed or anxious. It was up to the clinical providers to have that hunch to ask that
That is a
first.
great point. And then, so that raises the question of, okay, does the clinical provider have time in the traditional medical model to address that on top of all the other medical issues?
Mhm.
Oftentimes the answer is no, right? It sort of is like that wastebasket issue. It's like, well, we covered 5 things today. We're not going to go there.
Yes. That's why I switched to psychiatry, actually.
I mean, I think the other issue too, Dr. Esther really brought it up, is why aren't patients talking about it? It seems that there's a fairly significant stigma like, oh, there's something wrong with me that I might feel this way. And I almost wonder if sometimes they're a little embarrassed, like, I'm just here for my medical issues, but I don't really want to tell you what's going on in my head.
The stigma is still strong. I would say it's lessened much more than 10 years ago, now that I've been in practice at least that long, maybe almost double that. But yet in the medical world, like in the hospital or in the medical clinics, people still will not bring it up unless they were asked first.
With folks who are suffering from depression and insomnia, do you feel that the depression anxiety is being driven by that insomnia, or do you think the depression or anxiety is driving the insomnia, if that makes any sense? If you fix one, do you fix the other? How does the relationship between those diagnoses work?
The quick and easy answer is to tell you it's complicated, right? But what I look at it is I see there being an interaction that is bidirectional, if you will, or like almost like a circle or a vortex of like, I don't sleep well. That affects my mood. Then I feel really bad about what's going on. And then I feel more anxious and then I can't rest my brain at night. So I sleep worse. Like, I feel like it's this cycle that we get into.
Yeah, my answer is yes and yes.
Love that. Love that.
It is a vicious cycle because we do have to address both. In psychiatry, in our sessions, we actually try to reach the underlying problem and figure out what is the primary diagnoses, major depression versus generalized anxiety disorder, etc., and go for treating those. And then we might do an adjunct treatment for the insomnia concurrently while telling our patients, this is not forever. This is not meant to be forever, to continue taking the what we call hypnotic or sleep medicine. Many times I try not to even start it because they love it so much they don't want me to stop it. And so that's kind of why I say yes and yes to Andrew's question.
Are there any mental health disorders, Esther, that you see frequently that are strongly associated with sleep issues? Like if you had to pick, I don't know, your top 5, what would they be?
I would say number one is the depressive disorders. It's actually one of the 9 criteria, and you only need to meet 5 out of 9 for at least 14 days straight to meet the criteria for a major depressive episode. So that's always asked. We never miss that one. And it comes along with so many anxiety disorders, panic disorder, PTSD, also bipolar disorder, on the other hand, where there is a decreased need for sleep, which is interesting. They wouldn't even complain about insomnia. They would say, I don't need it. I can just thrive off of 3 hours a day. And they're kind of happy about it. And that's during their manic episode. Regarding ADHD, like insomnia is not part of the criteria for the diagnosis of ADHD, but it's interesting that I do meet a lot of children and teens and adults who can't fall asleep quickly. And it's not just because of the side effect of their medications, but just because their brain is constantly going and is very, very hyper. And there is this one case I'd love to share about that. He came to me thinking he had ADHD, and I didn't do objective testing and I didn't order it, and I should have. But I started him on a stimulant and it was partially effective. And later on, it dawned on him that his sleep, and he never complained to me that his sleep was so terrible. He went on ahead and got a sleep study on his own. He got his own referral, found someone to do a sleep study, and lo and behold, he was diagnosed with sleep apnea.
Oh, yeah.
Yeah, he received a CPAP and he felt so much better. His sleep was so improved. He stopped the ADHD stimulants and I removed the ADHD diagnosis because I misdiagnosed him. It was his poor concentration, his poor productivity, his poor organization, everything that looked like ADHD came from his obstructive sleep apnea.
That story is amazing because I 100% concur that I've seen this so many times. I primarily treat adult patients, but even adults will tell me, and sometimes it's years later, like they'll be like, well, I've had ADHD for a number of years. I've been on the stimulant medication, and they basically end up in my office for some other reason. Like I have high blood pressure now or diabetes and I'm overweight and my doctor thinks I have sleep apnea. And so in talking with them, it's amazing how many people don't realize that there is such a strong association with ADHD. And it's definitely something that we see in kids for sure. What's very interesting about the pediatric population is oftentimes kids may have issues with being irritable, concentrating, they may be getting in trouble at school. And one of the things I always encourage parents to think about is, hey, does your kid snore? Do you think they stop breathing? Is there something going on with their sleep? Because correcting that sleep issue may actually correct their concentration issues and everything. So I would say starting at as young an age as possible when you start to notice these things is huge. And yeah, to your point, 100%, I have definitely seen sleep apnea be an issue. For me, I've seen a variety of psychiatric disorders documented historically. And I did share with you a bit about this story when I met with you during our holiday time, the meeting that we had. But I wanted to share with my audience kind of a cool story, which is that of a patient who came to me carrying a diagnosis of bipolar disorder. It was interesting because there's so many different gradations, and I know you're the expert in this. So I'm not going to pretend to even tell you that there's mania and there's hypomania and there's gradations of the depression and gradations of the mania. And I could see where she's telling me, I come with this history, and I was very nervous about it. But what was odd was that she had the opposite of having difficulty sleeping. She couldn't keep her eyes open. She literally felt like she was missing out on the world. She was missing out on her kids growing up. She had a busy family life. And she just felt like she was abnormally tired, and she was a relatively young woman. And so in speaking with her, I was actually suspicious that maybe she doesn't have bipolar disorder, like maybe that isn't what's going on here. And so we tested her, and it turned out that she had narcolepsy. So we had an actual medical condition that was explaining a lot of her symptoms, and we got her on the right medications. And as I shared with you during the holiday party, I made sure that I had that dialogue with her psychiatrist, which again was not easy because there were many phone calls back and forth, but I got a hold of him, and we discussed her case, and he was comfortable with me actually initiating some management. I made her come in for close follow-up. I was like, "What's going on, girlfriend? How you feeling?" Because I wanted to make sure I wasn't going to throw her into some spin because I somehow, was mistreating her, and there truly was a bipolar disorder I was about to make worse. It turns out she eventually fought the diagnosis, to your point, and she's been doing wonderfully, getting treated just for her narcolepsy. There's been no manic episodes. There's been no major depression, which is just, it's mind blowing, right? When you think about it, for sure. I think a couple of other things that I think about when I think about how mental health and sleep can interact or intersect would be that we need to use a lot of medications often to treat folks with psychiatric issues, right? And then you would know better than me, Esther, but there's so many side effects sometimes with these medications. Like they may acutely help with the mood, but I've seen a number of schizophrenics or folks that have depression, and a lot of the antidepressants or the antipsychotics sometimes can be associated with weight gain. And so what I've seen is the patient may not have initially had symptoms of a sleep disorder, like sleep apnea would be what I'm referring to. But over the course of years of needing to have their psych issues managed, they end up gaining a tremendous amount of weight. And so now we see that they have two things going on. They've got the psych issues, and then they have the medical issue of actually having fairly significant sleep apnea. And it can be, what's your experience been with folks in weight gain, and how easy is it for them to actually get their weight down? I personally have observed some fairly significant challenges with weight loss.
Yes, that's a great question. I personally, in my practice, I try to detect that the weight gain is starting. And then I have to quickly try to change the regimen because after the weight has been gained to a moderate or even obese levels, then it is very, very difficult. And non-compliance, non-adherence to taking the medicine start to occur. So we try to monitor and manage as often as possible. Sometimes they can't live without the medication that's causing the appetite issue. So we would emphasize that their choice of dietary foods is very, very important, and that their mental health relies on choosing the right foods and exercise, etc. Sometimes I know this is recorded, but we have to use other meds to combat the appetite gain. For example, use something that helps reduce the appetite. So we're chasing the side effect to try to keep it appetite neutral in order to be able to use antipsychotics or those other medications. When I meet somebody already obese and already having medical issues, I try to work with them to, first of all, not be discouraged and try not to have body image issues, but to realize that they do have control over their BMI. Sometimes they blame everything else and everyone else, but once they have a realization that they can do something about it and still yet maintain their mental health by using the medication, then there's success in bringing down that BMI or body mass index.
Oh, that's such a helpful point and very useful information. Are there any specific recommendations in general that you can share, or specific medications that you found to be effective in managing that navigating that delicate weight gain issue?
Yeah, I would say amongst the second generation antipsychotics, I try to first use agents that have less of a infamous side effect of weight gain. For example, I try to avoid or try to choose later or last medications such as Zyprexa, Seroquel, Risperdal. Those three tend to really just ramp up that appetite, and we can see it very quickly. Um, Abilify, Geodone, some of those other antipsychotics have maybe a little less tendency, and then we can kind of gauge. But I would see it in all of them that sometimes certain individuals, they gain it all in that first month, and then we quickly pull back and then use something else. There are newer ones that have a label of this is less of a risk for metabolic syndrome, which means having that risk. But we have seen it with all of the antipsychotics that they have that risk. I'm glad to say many patients who do take these medicines and it doesn't affect their appetite at all. So I try not to scare my patients by saying this will increase your appetite. I try to share with them it may increase your appetite, but it may be very beneficial for your symptoms. So while you're starting on it, why don't you watch what you're eating and how much you're eating? And we start off that way. Sometimes they have no control. They just have just this voracious appetite and they eat everything they could see and get their hands on. Then I know that their self-control is so poor about eating, I have to pull back on those meds.
What you just said there, essentially, you emphasized something that made me so excited to work at Oak Health, which is primarily that you really cherish patient communication. That is so huge because so many people sometimes don't really even, it's as though they're getting a pill and they don't even really understand, what to expect with that. The fact that you take the time to explain that, every psychiatrist should be doing that. I'm not saying they're not, but I am saying I am impressed. I am impressed. So thank you for doing that because it's so key.
Oh, thank you.
So, Dr. Allison, we started off talking about sleep, and I'm convinced. I am ready to get a sleep study.
Yes.
What does that look like? What are you looking for in the sleep study? What is that like for the patient? Is there a reason to be nervous? What's the process of the sleep study? And then when you are looking at the results, what are the things that you are finding and looking for that help you with your patient?
Ooh, goody. We get to talk one of my favorite things. I love toys and gadgets. That's one of the reasons I love sleep so much is technology is always changing and I'm always curious about what's new. So if we go back to the 1970s, certainly before you were on this planet, Andrew, my young lad, um, but when we go back to then, that's really when sleep, that was sort of like sleep in its infancy. And the traditional model was the polysomnogram, which has a very interesting backstory because there was a gentleman, I want to say he was from Columbia University. I haven't thought about the story in quite a long time, but he was at a major university. And one of the things that he was doing was, I believe he was actually having some college students come over and sleep overnight so that he could kind of perfect this whole algorithm of the polysomnogram. And there are some funny stories where he used to get the side eye, put to you that way, because you can imagine this guy is trying to work on polysomnograms and there's like strange people going in and out of his apartment building in New York. And I'm sure the optics of that were probably hysterical. But nonetheless, the polysomnogram came to fruition. So that is the classic sleep study. That's the gold standard by which we observe everything. That gives you a lot of information in terms of what a sleep doctor would be able to get out of it. I would be looking at what we call your sleep architecture. What stages of non-rapid eye movement sleep you're going into? Are you going into rapid eye movement sleep? What does your sleep architecture look like? How many sleep cycles are you getting through over the course of an evening? Typically, a sleep cycle is roughly about 90 minutes or so, and then, sort of have a new sleep cycle. We have 3 or 4 of those over the course of the evening, and then you're sort of done sleeping for the day, or for the evening, I should say. We can also tell what's going on with your breathing, what's going on with your oxygen levels, what position you're sleeping in, what is going on with your heart rhythm to a certain extent, because we monitor that parameter. We're looking to see if you have sleep disordered breathing. Do you kick your legs? We videotape you. So are you punching or kicking or acting out your dreams in any way? So a lot of information can happen with a polysomnogram. What we do know more recently is that a lot of data can be gleaned without you necessarily needing to go in for a polysomnogram. So if you can imagine, polysomnograms are wonderful. I love them. They give tons of data for me. But if you're from the patient perspective, and I've been someone who's had a polysomnogram, so I can attest to this, and I have long hair. I have it up in a bun right now. But imagine I take my hair out. They glue 30 electrodes to this long hair of mine. And then they, hook you up with bands and wires and a nasal cannula and electrodes on your legs. And then it's a person you don't even really know all that well. And you go into a room and they're like, okay, you can relax now and go to sleep. What does that look like? We call that a first night effect because there's so many folks that may really struggle to actually sleep over the course of the night. And the next day, I don't know if you guys ever saw the cartoon Fraggle Rock, but I look like a Fraggle. Like my hair's out of control. There's not enough shampoo or conditioner in the world to make it even remotely manageable for me to comb all the goo out of my hair. So it is quite an experience. We now can simplify that experience in the comfort of your own home. FDA approved are a number of brands of what we call home sleep testing. So what home sleep testing really is it's a device that goes home with you. And there's some devices work off of algorithms where there's changes in what we call the peripheral, meaning distal, further away from the heart, arterial tone. The arteries are what bring blood. It's basically what gives you a pulse. If you can imagine, you can feel your wrist, you can feel a pulse. That's your artery. So we're measuring changes in that tonicity. That's one style of device. A more traditional device may be monitoring what your respiratory efforts are related, how you're breathing, your respiratory efforts. They may monitor what's going on with your oxygen levels, what the flow is, what position you're sleeping in, and using what we call actigraphy, movement. It estimates or guesstimates, is probably the more accurate word, how much time you're actually sleeping. And so that, coupled with what your breathing pattern or what the algorithm is demonstrating, will tell us whether or not you have sleep disorder breathing. The correlation is usually pretty good, around 90% with polysomnogram. So it's very useful if I'm concerned that Andrew has sleep apnea for me to use that. The key is, how concerned is Dr. Kole, right? So if I'm very concerned, and Andrew, you come to me and I suggest we do a sleep test and I look at the data and it seems great, but the test doesn't show that you have sleep apnea, I have to be thinking, well, are you one of the 10%? Did I miss something? It's not perfect. So in that case, I often may suggest either doing a more detailed home test. Knox is a specific sleep company, and they actually have a device that will do something sort of equivalent to a polysomnogram. Or do I send you for an actual in-lab sleep study so that I can get that data? And obviously, for the sake of minimizing your torture, I would say I'd rip the Band-Aid off and send you for a sleep study because at least I would know what I'm dealing with here. They do make other types of tests, like I said, that are a little bit more detailed, but in general, that's the traditional home sleep test that we use. If you're a low probability patient, meaning I don't really think you have sleep apnea, I'm probably going to feel fairly comfortable that your home sleep test is probably not demonstrated. If it's negative, it's probably really negative. There's always the option to send someone to the lab. Oftentimes, if they kind of don't think they have it and I kind of think they don't have it and the data doesn't show that they have it, they sort of want to leave it alone. They go, well, I don't really think I need to go through the hassle of trying to get an in-lab sleep study, approved via insurance. The cost is an issue for the in-labs. They are considerably more expensive, whereas home sleep testing can be made very affordable for most patients. So that is another advantage of doing that. Hopefully, I know that was detailed, but hopefully that answered your question.
That's very helpful. And I would agree with what you said about affordability. That's why we love having you as a part of the Oak Health Center team. It really does. You're such a valuable resource. And that brings me to my next question for both of you. In what are the benefits that you see with this sleep and mental health care, treatment partnership? And what made you excited and motivated you or to do this and to come together and work together and create this partnership and relationship with the two different fields?
I'll go first. I would have to say most psychiatrists, such as myself, we spend maybe a half hour for our follow-up medical visits, and maybe a portion of that is checking up on sleep. And we don't have enough exposure to all the other sleep disorders, medical sleep disorders, to detect that. And sometimes, if we even have that suspicion, we always have to refer out. And many times, my clients have a resistance to that. They they feel like it might be expensive, or they're just afraid of being diagnosed, or they think I'm just referring out of a small suspicion. And invariably, they'll just say, "Well, just change my sleep medicine." And I have done that. I have sometimes utilized up to 10 different choices, and their sleep is still poor. So when we met Dr. Kole and thought, wow, we can have a referral source within Oak Hill Center, and we can say she is the sleep specialist, to know that a sleep study would be very beneficial. Uh, it was more convincing for me that we needed to do this, because so many of my clients of greater like 10 plus years have had sleep struggles. And even right now, I still have some challenges convincing some of them to meet Dr. Kole, because I've been telling them, would you like to meet Dr. Kole? and and those who have so far have been enlightened, educated, and also adjusted their medications for the better. So that's one testimony I already have as we started to work together.
That is awesome.
Yeah. I could say for me, like I mentioned to you, psychiatry has always been like black box. I'm not allowed. I have to go find it. I have to dig it out of the airplane and somehow get someone to let me see what's behind the curtain, if you will. And yet so much of sleep, particularly the more difficult patients, which are the folks that don't sleep well, there's typically so much overlap, as we've discussed, with some sort of an issue. Maybe it's bipolar disorder, maybe it's anxiety, maybe it's depression, maybe it's a combination. We've talked about so much overlap between the two, and yet I'm never allowed to see that in a traditional sleep practice. So my patients are actually a different type of patient at Oak Health Center than perhaps I'm used to. They're definitely very challenging. I can say that Esther is not referring me patients that are easy. She certainly gives me the more challenging cases. And I love that. That's just, it's fun, forces me to really think outside the box. And I get access to information about a patient that there's no way I would ever find that out. And like I said, unless I made the extra effort to have a separate conversation with a provider who's not within my practice that I'm trying to get a hold of. And sometimes these folks are very like, well, I need to make sure they need to fill out paperwork. They need to confirm that it's okay for me to speak to you. Whereas when we're all integrated, we have that knowledge. They're physically making that appointment. There is an agreement intrinsically there. Yes, we're all in the same electronic medical record. There's no hiding that information. And that information has literally been invaluable to me in being able to get them further along than I would with some folks that I've seen where I know there's something else going on, but they're just not going to share it with me. What is the magic pill? What is the easy fix? And unfortunately, in sleep, that is the one thing that is very tricky. Occasionally, we find something that really works for patients that is a pill or a pharmacotherapy, but more often than not, the success rates just aren't there, as you can attest to, Esther. having had to sometimes switch people. I mean, the laundry list of medications you've given folks sometimes when I've seen it, I'm like, I wouldn't even know what to offer. Is there anything else? Yeah, like I feel like there's nothing else left. You've literally left no stone unturned. Well, that's another joy of mine is that if someone else has already done some of the hard work, which is the changing of the scripts. So then I come in and I can swoop in and be like, guess what? There's this thing called cognitive behavioral therapy for insomnia, and I'm going to fix you. I promise you, you will initially hate me, but hopefully you will love me at the end. And so far, so good. So far, we've had some success with that. So thank you for trusting me with that.
I'm so glad you brought up the cognitive behavioral therapy for sleep. And it's interesting. We talked a lot about sleeping pills, but I do find, just in general, you talked about with mental health care, there's stigma attached to it. What do you tell patients who come to you and say, I need sleeping pills, and you suggest therapy? And they say, why do I need therapy? Why can't I just take my sleeping pills? Why is it important to incorporate therapy, whether it's on the sleep side or mental health side? Why does that have such a impact on quality of sleep as well?
That is such a good question. So good, so good. You know, at the end of the day, as I pointed out in the beginning, let's go back to the data. What does it show? This is not just like Dr. Cole's random opinion about sleep. What have people looked at? Where is the data, right? So you have data from pharmacotherapy. So you have data from sleeping pills. Those sleeping pills come from pharmaceutical companies. Those companies do arrange for testing that's randomized. And what have they really shown? Well, there's clearly an improvement in sleep. We know that clinically in real time. But what's interesting is maybe the extension in sleep, depending on whether or not it's meant to keep you asleep or help you fall asleep, you might be looking at the order of maybe 20 minutes longer when you really drill down in the data. Yeah, it's better than 0 minutes, right? So there's a statistically significant change. But when you look at folks and you then start to say, okay, are there behavioral interventions that we can do? The data simply is better for cognitive behavioral therapy versus pharmacotherapy alone. And I do believe they're looking at whether or not there's some utility to overlapping the two. And I believe in clinical practice, I would argue that there is. There are folks that sometimes the combination of cognitive behavioral therapy plus some pharmacotherapy may be the magic that gets them to where they need to be. But the vast majority of patients will not require a pill to take in order to sleep. The data just doesn't support it. What I can say too is that whenever we give anybody anything, right? Prescribing medications, regardless of what it looks like, or if you're prescribing cognitive behavioral therapy, what are the risks and benefits of that? If I'm prescribing you a sleeping pill, what are the risks and benefits of that? If you think about someone undergoing a therapeutic program where I'm not physically giving you anything that may alter your brain chemistry, or I'm not giving you a sedative hypnotic that's going to put you to sleep, the bottom line is that the risks are essentially pretty low. And then we find the benefits are fairly substantial. Whereas with some of the sleeping pills, some of the sedative hypnotics out there, there are some serious concerns that even the non-prescriptions, such as the first generation antihistamines like diphenhydramine, for example, also known as Benadryl, that there may be some issues related to cognitive impairment. I can tell you I've definitely seen that with older folks, and I suspect that there may be issues with how folks metabolize drugs as they get older. I'm sure there's a slew of reasons. That's the one that comes to the top of my head. Something to do. But at the end of the day, and also too, is like, if you're looking at an older person, they're probably more likely to develop dementia issues or anything just by virtue of the fact they've been on the planet longer, and that tends to occur. There's a lot of things we don't understand in medicine, right? So are the benefits there versus the risks? And in a lot of older folks, the risks probably outweigh the benefits of relying heavily on giving someone a sleeping pill versus not, at least for the pills that are available today. Yeah, that's my answer for you.
Yes, I agree with that. Regarding the more elderly clients, they are so used to being put out quickly with medications. And then the longer they use, especially the benzodiazepines, like the Klonopin, Ativan, Xanax type of medications, the longer they use them, the tolerance builds up. They need higher and higher doses. And then they start, even at the higher doses, they are less and less effective. And then we're really in a bind. So I highly agree with cognitive behavioral therapy, especially for the elderly. I had one client who was in her 70s. She was still on sleeping pills, I have to confess. One of her main problems was anxiety about not being able to fall asleep. And so that was a perpetual problem. And her therapist did cognitive behavioral therapy just for that thought. I don't know if it was useful at that time, but I remember her therapist focusing on that.
And therapy doesn't just have to be the true cognitive behavioral therapy for insomnia. Sometimes that's sort of an umbrella term, if you will. But within that, there's different types of therapies that might be helpful. Is it important for someone such as your patient to restructure their thoughts surrounding sleep? Do they have some sort of a trauma that is going to affect their ability to sleep at night? And maybe they're more what we call hypervigilant. They're more aware of what's going on, or they don't perceive that they're safe. Is there a way to create a plan for them where they do feel safe, which will allow them to sleep? So there's so many nuances, right? Where I would say the number one recommendation is cognitive behavioral therapy. And I think it's for a reason. And so that's what I try to get folks to understand. I'm like, it's painful. You're probably not going to like it a whole lot. But in the end, if you can stick with it, part of this is their buy-in. They have to be emotionally prepared for that too. I think that is a factor for sure.
And nothing good comes easy, right?
Exactly.
I probably would reframe it. I wouldn't say it would be so painful. I will say it might take a lot of work, but it will be fruitful.
Esther, I love that. I am going to use it. It's just that the reason I use it that way is so that, I don't know, maybe it's because if I said it's going to take a lot of work, then they're surprised by how much work and then they kind of hate me more. So it tends to work better if I just cut to the chase. But I am going to try that technique and see what happens at the end. Do they hate me more or not? Because I guarantee you they're going to sleep better.
Okay.
But I love that reframing because it is putting a more positive spin. And that is something that I've tried to do in my life, is try to see more of the glasses half full perspective. And I encourage all my patients to do the same, if you will.
I can't imagine any of your patients hating you, Dr. Allison. That's impossible.
Oh, I love you already, Andrew.
And you mentioned time. There is one last thing I think it would be great to hear from you. What does healthy sleep look like? I feel like a lot of people don't even know what their sleep should be. And they might not know that they should see you for a sleep study. So what does healthy sleep look like for someone?
Ah, yes. So healthy sleep. The one thing to remember about sleep is healthy sleep is in part, sort of in the eye of the beholder. What do I mean by that? Well, if you listen to the media enough, everything nowadays is geared toward that 30-second blip. People die if they don't sleep enough. Okay, well, that just freaked me out. There's some catchy way that people phrase it, and then that's the information that they absorb, right? So it's a very narrow scope of thinking. I encourage people to be broader in their thinking about sleep, meaning, if you look at sleep and what's considered to be a normal amount of sleep, right? That's one way to look at it. What's a sufficient amount of sleep? A sufficient amount of sleep, or healthy sleep per se, would be, generally speaking, for most people, probably around 7.5 to 8 hours, right? But if you remember in school, you had your players that were amazing, right? They were getting the 90s and 100s, doing really well in school. And then you had your jokesters that were barely graduating, right? There's that bell-shaped curve. So the majority of people are going to fit into, hey, I need about 7.5 to 8 hours of sleep to feel good. But there are definitely folks that generally may be shorter sleepers. There's actually some data that they're looking at now for a genetic tendency for some people to be shorter sleepers, like more in the 6-hour range. That's what I'm referring to. Shorter than that, I do think that there are some serious issues that could come about if you're really sleeping less than 6 hours. But if you feel good, what is your perception of sleep? Do you feel good? Do you feel refreshed around 6 hours? You feel like you have great energy. You don't feel tired. You may just simply be a shorter sleeper. On the flip side, there are folks that will come and they'll get a solid 8 hours. And they're like, listen, since I was a kid, I've needed 9 or 10 hours. But then they grow up and become adults. And as we know, we're adults in America. So we work really hard. And all of a sudden, they can't get really more than 8 hours and they feel tired, per se. Is it that there's something intrinsically wrong with them, or are they longer sleepers and they need more like 9 or 10 hours to feel okay? The other aspect of healthy sleep is it whether or not you perceive that it's a good quality of sleep. So, are you getting a solid 8 hours, for example, and generally speaking, having few awakenings at night, and you're able to easily fall back asleep and you wake up feeling like you got a good night's rest? Okay. You know, or are you somebody who is feeling like there's a lot of awakenings at night? You're maybe not able to fall back asleep very easily. And you wake up and you're like, something just feels off. Like I don't feel really refreshed. So there's a lot of variables, but really, when you think about it, it's are you getting sufficient sleep for you? And that, again, may look different to different people. And how is your sleep quality? And a lot of sleep is your perception. So that does mean a lot. That being said, I would make the argument that if Andrew were to come to me and he says, listen, doc, I sleep great. I sleep fine. And Mrs. Andrew sits there and goes, you're not breathing at night. You're freaking me out. I've got to elbow you every 5 minutes. Like something's wrong with you, right? I really do believe, in addition to your personal perception, it's especially helpful if you have a significant other who might be able to go, you know what? There is something wrong here. Don't ignore that. Don't ignore that. I can't tell you how many people I've seen in my office where, they're on their second marriage now. They've been divorced and they're coming in because the second wife or the second husband is like, listen, you're making so much noise. I can't stand it anymore. And they're like, hey, maybe I should really take this seriously. Do you think spouse number one was okay with their sleep? Probably not. They just didn't care enough about him to do anything about it. So I would make the argument, don't ignore those, if people are raising concerns too, keep that in mind, have an open mind. It doesn't really hurt to get your sleep checked out. And true story, another true quick story, which is kind of a fun story. I had a lovely gentleman. He's a big guy, real big, his body mass index had to be in the 50 plus range. But came in full of energy, felt great. He's like, listen, I sleep fine. I know I snore. I have a little high blood pressure. But other than that, I'm a rock star. All is well. I don't really think I need the study. And I'm like, respectfully, you need the study. You're really heavy. You have a big neck. You have high blood pressure. You've got some of these other things that are more concerning. And I wouldn't feel good about myself if I told someone who had obesity, essentially, that they shouldn't have a sleep study. I just don't know that I could justify that in my brain. And if the other more clinical side of me is going, well, according to the stop bang, you have a lot of risk factors. And so you're high probability and I need to test you. So there's a couple things at play. It's sort of my gestalt plus, sort of your clinical background and information that we know has been documented. We did a test on him. Terrible sleep apnea. You ask him how sleepy you are. I don't sleep. I'm not sleepy at all. Doesn't bother me. No siree. So I put him on treatment. He comes back to see me. I was like, there's no way this guy's even going to use this machine. He doesn't even believe he has sleep apnea. He thinks I'm crazy. I put him on therapy and he's like, doc, I sleep so much better. I have so much energy. I'm like, well, you had a lot of energy before. I don't know what's going on right now. But you can always hear exceptions to the rule, basically. But, if your spidey sense is kind of telling you, that's what I call my intuition, my little spidey sense. If there's some sense that there's something amiss, explore it. You're probably going to be healthier for it, is what I would say.
I think I need to sign up for a sleep study. You've convinced me.
Yes. So thank you guys so much for your time. I know this was sort of a longer podcast, but we covered so many really cool topics. Andrew, thank you for brainstorming and coming up with these amazing questions. I'm hoping that our audience has learned quite a bit from this. So if you are interested in a psychiatric evaluation, Dr. Esther Park and her multiple colleagues are all available for consultation. You can go to the Oak Health Center website. They're based in Laguna Hills, and they do telemedicine and in-person. For me, I'm actually based in New Jersey, and so I'm available for telemedicine consultation. I am now currently seeing patients in California, New Jersey, and Georgia. I have a new medical license. If you'd like to have more information about what the sleep program is all about and what we offer, you can go to oak.care/sleep. Also in the works is going to be Ask the Sleep MD. Did I say that right? Yeah. What's the name of my website? Yeah. AskTheSleepMD.com. It is under construction. It hasn't been fully vetted yet, but there hopefully will be lots more blog posts, etc., on that website in the future. Thank you all so much for sticking with us for this extra long podcast today. Awesome stuff. Bye, guys. I really hate to have to do this, but these are my terms and disclaimer. This podcast is intended for persons 18 years or older. This podcast provides general information and discussion about medicine, health, and related subjects. The words and other content provided in this podcast and in any linked videos and materials are not intended and should not be construed as medical advice. If the listener or any other person has a medical concern, he or she should consult with an appropriately licensed physician or other healthcare worker. The views expressed on this podcast and YouTube channel have no relation to those of any academic hospital practice or other institution with which the authors are affiliated. There is a detailed terms of use agreement. You can see it all on the YouTube channel. In the interest of brevity and the fact that it's legalese and really hard to read, I am not going to read it. But accessing, reading, or otherwise using the podcast or YouTube channel does not create a physician-patient relationship between you and me. Providing personal or medical information to me does not create a physician-patient relationship between you or me or any other contributors to this podcast. Nothing contained in the site is intended to establish a physician-patient relationship, to replace the services of a trained physician or healthcare professional, or otherwise to be a substitute for professional medical advice, diagnosis, or treatment. You hereby agree that you shall not make any medical or health-related decision based in whole or in part on anything contained in the site. You should not rely on any of the information contained in the site and related materials in making medical, health-related, or other decisions. You should consult a licensed physician or appropriately credentialed healthcare worker in your community in all matters relating to your health. You agree to indemnify and hold the author harmless from any claim or demand, including attorney's fees, made by any third party as a result of any content posted or made available to you by the site, any violation of law that occurs by you through the site, or anything you do using the site or the content contained therein. This entire disclaimer also applies to any guests or contributors to the podcast.